the nice introduction. And thank you, Clarinet, for providing this platform for the PG teaching. E-Gurukul is very favorite special program, especially considering the PGs to teach, to learn everything. And for today, we have a webinar on the seminar on the neonatal seizures. For this, we have Dr. Anish to present the seminar. And Anish is a DM neonatology resident at Pramukh Swami Medical College, Karamsad in Gujarat. His mentor, Dr. Somshekhar Nimbalkar. Sir doesn't need any introduction, but he's professor in neonatology in the institute, and he is also an advisor for this e-Gurukul program. For this, we have two eminent experts. I welcome Dr. Shilpa Kalane ma'am. She is at present at the Dinanath Mangeshkar Hospital. She is a consultant pediatric she is a consultant neonatologist, and her area of interest is perinatology, neonatal resuscitation, and neonatal neurology. She is an examiner for DNB neonatology. She has been awarded with the NNF and IIP neonatology fellowship. She is guide for DNB pediatrics, and she is trainer of the NRP FGM, national faculty for many other modules with simulations, and she has many publications. Welcome, ma'am. Dr. Harsh, Dr. Harsh will be joining as a second expert with us in few moments. Dr. Harsh is a pediatric neurologist and consultant pediatric neurologist at the Zydus Hospital, Ahmedabad. He has many publications. He has co-authored in 6 books, including the IIP textbook of pediatrics and IIP textbooks of pediatric and neonatal emergencies. He is reviewer also in the Indian Pediatrics and BMC Neurology. He was an EB member of FLICNA and core committee member of Young Epilepsy Section. He has been awarded with the original research on epilepsy tool, which got at AIMS Best Clinical Research Award in 2016-17. His special clinical interests are in the drug-resistant childhood epilepsy, neurogenetic disorders, autoimmune CNS disorder, and neuromuscular disorder. Welcome, Dr. Harsh. So for today, it's all about the neonatal seizures, and we have 2 eminent experts to guide us through the seminars. We will be discussing each and every small things regarding this. Anybody who have joined can ask the questions, can clear their doubt. So I request Anish to please go ahead with the presentation.
Yes, ma'am.
Somshekhar sir, you want to say something?
Yeah, thank you. So one of the things is neonatology is a changing branch, and a lot of things change every now and then. So it's important to keep track of what do you say, advances that happen. While case presentations are good and they allow you to discuss actual cases, we feel that occasionally once in a month or once in 2 months, having a presentation per se would help people update their knowledge on what has changed. Commonly, was what we see in say resuscitation or hypothermia, etc. So many things have changed, and things are not the same as they were before. So it's important to keep updated with changes, and it's important to understand how to analyze how the changes have happened also. So I hope this presentation that Anish is doing will help many people to get updated with neonatal seizures, and I'm sure Dr. Shilpa and Dr. Harsh will be able to add their experience to whatever Anish presents. Thank you very much, and I thank everyone for joining, and hope that it is a very good learning session. Thanks to Dr. Shilpa and Dr. Harsh for agreeing to join on a Saturday evening, when usually we would want to go out for movies or outside things. Thank you.
Thank you, sir.
So Shilpa ma'am, the flow will be Anish is presenting the seminar, but you can interrupt at any minutes, and you can discuss whatever is there. The students can also put something on the chat box so that the flow will not be disturbed. But when the discussion is going on, they can definitely start their mic and they can ask something.
Oh,
So welcome all,
great.
and please, Anish, go ahead.
Thank you. Thank you.
Start with the first slide, right? Go to the top.
Yes, ma'am.
Yeah.
Yes. So, good evening, everyone. I will be presenting a seminar on neonatal seizure and its recent updates. So, my mentor is Dr. Shomshekhar Malkar, sir, and I will be presenting the slide. So, the learning objectives of this session will be: what's the problems statement in neonatal seizure? What are the peculiarities of the newborn with neonatal seizure? What's the pathophysiology behind it? What's the classification and types of the neonatal seizures? Etiology, and the most important part will be the recent updates on treatment and the management. So going ahead. So what's the problem statement? As we all know, the incidence depends on the birth weight and the gestation, and it is the most common in BLBW infants, and that is the very low birth weight infants, and that is 36.1 per thousand live births, and that is according to the data that is by NNPD. Preterm infants had almost twice the incidence when compared to the term units. And the term infants in the high income countries, the seizure incidence rate is 1 to 3.5 per thousand live births. And Indian data, it is less well studied. And according to the International Neonatal Consortium, the incidence is 6 by 1000 live births. And at around 30% units with neonatal seizures develop CP, 15 to 35% develop epilepsy, and the 50% have developmental delay. So, what are the pictures? Mostly acute symptomatic seizures, and they occur in the developing brain, unlike the adults, which occur in the mature brain. And what are the neuroanatomical features, neurophysiological features behind it, and how the recognition is difficult in newborns as compared to the adult, and what are the diagnostic dilemmas, and what are the treatment, that is the updates on the treatment, drugs, and the approach, and the long-term effects. So what is the neonatal seizure? So it is, as everybody well know about it, that is, it is the paroxysmal alteration in the neurological function that may be in the form of behavioral change, motor change, or autonomic change, and they may or may not be temporarily associated with the surface electrode electrical changes, and it is up to 44 weeks of corrected gestational age. So how is it different from the adult seizures? So as the neonatal seizures are electrical in onset, symptomatic, and mostly provoked, they are focal or multifocal. What does that mean? That a focal is like it has a focus that is occurring from within the one hemisphere, and the secondary generalization that is seen in the adults is very rare. So in the newborn brain, excessive depolarization may occur because of the imbalance of the neural excitation over the inhibition, as the excitatory neurotransmitters are more in the developing brain as compared to the adult brain. So how is the spread of seizure? I have already told, that occurs within the one hemisphere, and the secondary generalization is very rare, and the newborns rarely have well-organized generalized tonic-clonic seizures, and premature infants even have less well-organized seizures as compared to the adults and the term babies. So what's
Anish,
the mechanism behind? Yes,
I
yes, ma'am.
just want to know, you're saying the neonatal seizures are provoked.
Provoked. Yes, ma'am.
What do you mean by that?
Ma'am, it is provoked means like it is due to the some electrical imbalance, like in cases of hypoxia or IVH or hypoglycemic. So there is some symptom or etiology behind it that leads to the seizures.
Okay. So provoke means there is, you're talking about the etiology. There is some cause for the seizure,
Yes,
right?
yes,
Okay.
yes, yes. So
Go ahead.
the next part is what's the mechanism of neonatal seizures. As I have already told, in the developing brain there is more of excitatory things. So it is like they have more of NMDA receptors, AMPA receptors. That is N-methyl D-aspartate, and that is more, and that causes more excitatory thing and causes more excitatory imbalance as compared to the inhibitory imbalance. Furthermore, the thing of the immature brain, that is the GABA. So the GABA is inhibitory more in the mature brain because of there are two channels. One is, as you can all see, there is NKCC1 and the other is KCC1. So the NKCC1 is, what does it do? It causes influx of chloride ions, and that leads to influx of chloride ions. So the intracellular part, it has more of chloride ions, and whenever the stimulate occurs, the chloride ions will go out and will cause depolarization. So again, it will lead to the neonatal seizure in the immature brain. This is the same part how it causes excitation. So the pathophysiology. The pathophysiology is according to the symptoms. So if you see, first is like failure of ATP dependent sodium potassium pump. That is mostly seen in the HIE and the hypoglycemia cases. So it will again cause more Na to go out and will cause depolarization. Second, I have already told, that is physiological. That is what? Excess of the excitatory neurotransmitters and the relative deficiency of the inhibitory neurotransmitters. Third, as we already know, the metabolic disturbance, for example, pyridoxine deficiency, folinic acid responsiveness, biotin dependency, biotin deficiency, these all will cause membrane alteration and will cause increased sodium permeability, which will cause further depolarization and further will cause neonatal seizures. And the last is influence of the calcium and magnesium over the sodium channel, that we know is hypocalcemia and hypomagnesemia leading to seizure. So that was all about the the pathophysiology. The other thing is neuroanatomical features that we have discussed somewhat in the neonatal brain, that is electrical onset, focal, and which is occurring within the one hemisphere. And we have already discussed that secondary generalization is very rare. Now it depends all upon the phase of development. As the brain is developing, so the lamination of cortical neurons is usually completed by the term neurite growth, and synaptogenesis is rudimentary. So it leads to poor propagation and sustainability. There is deficient myelination of the cortical efferent neurons as compared to the myelination of the limbic system. So the neurons of the limbic system are more developed and well connected with the diencephalon and the brainstem, and that will lead to the increased orobuccal movements, lingual movements, and apneas. That's why in the babies we see more of lip smacking, chewing, paddling movement. So we more see in that. So other thing is neurophysiological features. That is, relation of the excitatory inhibitory synapses will determine the formation of discharge and the spread. And the neonatal period will be characterized by the higher levels of excitatory neuron. And the excitatory activity, as I have already explained, it is by the NMDA and the AMPA. And the principal inhibitory neurotransmitter is GABA. So what does the NMDA receptor exhibit in the neonatal brain? That is, it causes prolonged duration of the NMDA mediated excitatory postsynaptic potential. It causes reduced ability of the magnesium to block the NMDA receptor. And the inhibitory polyamine binding sites are very less. And there is greater sensitivity to the glycine enhancement. So that will cause again seizures propensity or seizures to occur. Third thing is AMPA receptors are overexpressed and have a subunit glutamate receptor 2 deficiency that will again cause excitation. And as I have already told, there is GABA is excited due to the mismatch between the two transporters, that is NKCC1 and KCC2. So NKCC1 is, so there are two things, the mature brain and the immature brain. So during the perinatal phase, the NKCC1 is increased, which will cause more of excitation. And in the this is mature brain, which will cause more of inhibition. So influx of Cl that will cause hyperpolarization. So that is all about the neuroanatomical features, physiological things, and the neurophysiological features. Now, how does the seizures affect the energy metabolism? So this is associated with the increased rate of the energy dependent ion pumping that causes ATP to break down and will cause increase of ADP. So the increase of ADP will cause stimulation of the glycolysis at the rate limiting step, that is glucose conversion to the pyruvate and then further conversion to the lactate and the hydrogen ion, and will cause the cycle to proceed in the anaerobic glycolysis. And what is the mechanism of the brain injury? So it depends on the two things, whether it is prolonged seizures or whether it is recurrent seizures. The prolonged seizures will lead to the cell loss and the recurrent seizures will lead to the altered development. And in the developing brain, the threshold for the seizure generation is very low and it is very less vulnerable to the injury from the prolonged seizure. That is due to the lower density of the active synapses, lower energy consumption, and immaturity of the biochemical cascades to the cell death. So now the seizures definitions. So the International
Hold on.
League of Task Force, yes,
Dr. Anish, could you explain
Yes,
what
ma'am.
is electroclinical uncoupling or dissociation?
So, ma'am, electrochemical uncoupling is the thing whenever we give GABA agonist, for example, barbiturates. So, what happens is the motor symptoms, the
Agonist or antagonist?
agonist,
Okay.
agonist, that is barbiturates. So, whenever we give that, the motor symptoms usually subside, but the electrical symptoms that is seen on the EEG will persist. So, that is called as the electroclinical uncoupling. That is seen with the GABA agonist.
Why is it like this? Why is it seen like in that way?
Because of the NKCC1 receptor is there that causes influx of Cl minus, and whenever we give GABA agonist, it will cause depolarization. That will cause electrical changes to be persisting, and the motor part, the myelination that occurs, it is caudorostral. So the spinal cord and the brainstem, that will be myelinated. So the motor symptom will stop, but the electrical system will persist, and that lead to the electroclinical uncoupling.
Excellent. Yes, go ahead.
Yeah, thank you. Forms with a beginning and as well as an end. So the duration is not defined, but has to be sufficient to
We can't hear you. Dr. Anish, we can't hear you.
I think it is connectivity. We'll just wait. Anish, we can't hear you. Can you connect through the mobile or something like that so more connectivity is not lost? I got disconnected completely.
Let's wait for some time that he will join again.
I will just call him and find out what is happening.
So should I call or you are calling?
I'm talking to him. तुम join कर रहे हो ना? Okay, 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 okay. Yeah.
I will just call him and find out.
No, he's joining. He's got disconnected. He's joining in a minute.
Okay, okay, sir. Sir, should I call or you are calling?
नहीं मैंने बात किया उससे. I spoke to him.
I'm talking to him. तुम join कर रहे हो ना?
Okay, okay. There is all delay.
I will just call him and find out.
Okay.
He's joined. Start from ILE definition of seizure.
Yes, ma'am. So, ILE definition of seizure. It is an electrographic event with a pattern characterized by sudden, repetitive, evolving stereotype waveforms with a beginning and end. And the duration is not defined, but has to be sufficient to demonstrate the evolution in frequency and the morphology of the discharges, and need to be long enough to allow the recognition of onset, evolution, and resolution of the abnormal discharge. And the American Clinical Neurophysiological Society has given a definition for electrographic neonatal seizures, that is, it is an event which is defined by a repetitive evolving pattern with a minimum 2 microvolts peak to peak voltage and duration of at least 10 seconds.
So what is the
And-
difference? What is the difference between seizure, convulsion, and epilepsy?
When seizure is a electrochemical seizure is electrical event in the brain. Convulsion is a motor manifestation of the seizure, and epilepsy is the syndrome that combines all of the things, and that is epilepsy.
Seizure is sudden paroxysmal change
Movement. Yes.
in the brain function, right? Convulsion is motor
It's a
manifestation.
motor fin. Yes.
A seizure is the occurrence that time, but epilepsy is repeated occurrence of seizure.
Seizure.
Okay, which will be
Yes, ma'am.
chronic.
Chronic.
Yes, that's the difference.
Yes, ma'am. Yes, ma'am. So
Please go ahead.
Types of newborn with neonatal seizure. So the seizure is defined as a paroxysmal alteration in the neurological function. So a consensus statement by the neonatal EEG terminology defined 3 types of seizure: clinical seizures, electroclinical seizures, and EEG seizures. So clinical seizures is the sudden paroxysmal movement with or without EEG correlate. Electroclinical seizures, clinical seizures coupled with the EEG seizure, and EEG only seizures. That is, there is an EEG seizure which is not associated with the visible clinical sign, that is also called as subclinical, non-convulsive, or occult seizures. So what's the criteria for the electrographic criteria for the? Yes.
Yeah, Anish.
Yes.
So this is the guideline which you're talking about is published in 2020.
Yes, ma'am. ILE 2020.
Yeah. So 2023 is the recent guideline published. It doesn't
Yes,
talk
ma'am.
about clinical seizures.
Okay.
Okay. There are
Yes,
only EEG only seizures,
Seizures.
electrographic seizures, and electroclinical seizures.
Clinical seizures. Okay.
Okay. So electrographic seizures are the non-convulsive phenomena.
Yes, sir.
Electroclinical seizures are the EEG seizures plus clinical seizures.
Clinical seizures.
And the EEG only seizures are you can see only seizures only on EEG.
EEG.
Right? So your
Yes.
electrographic seizures, electroclinical seizures, and EEG only seizures. The clinical only seizures has been omitted now.
Omitted. Okay.
Yeah. Okay.
Yes, ma'am. So criteria for the newborn with neonatal seizure, electrographical criteria, that is sudden change in EEG, repetitive waveforms that evolve in the morphology, frequency, and the location. Amplitude should be of at least 2 microvolt. Duration should be of at least 10 seconds, and seizures must be separated by at least 10 seconds to be considered separate. So this was again ILE 2020. So ILAE presents a new classification framework of seizures in the neonatal period. which was in the line with the 2017 ILAE classification. It emphasizes the key role of EEG for the diagnosis of seizures in this age group. And seizures are mostly focal at onset, so the division of focal and generalization has been omitted. And seizures can occur that you have told, ma'am, that there are electrographic seizures and electroclinical seizures. And descriptors are determined by the predominant clinical features that are divided into motor, non-motor, and sequential. So this is the diagnostic framework. That is, if the baby is critically ill or if there is a clinical suspicion, so video EEG or AEG, if you find there is non-seizure episodes and or if there are seizures with EEG correlate, then it is electroclinical with clinical sign, and one is electrographic only, that is without clinical signs. So in electroclinical, the clinical manifestations may be motor, non-motor, sequential, and unclassified. So motor can be in form of automatism, clonic, epileptic spasms, myoclonic, and tonic. Non-motor can be in the form of sudden increase of heart rate, sudden decrease of heart rate, that is autonomic, the behavioral arrest, and the sequential and the unclassified. So that was the diagnostic
What is,
framework. And
yes. So what is this non-seizure episode?
these are the episodes which have no EEG. Like at the time of the starting of the seizure, there will be no pattern on the AEG. So that's why they are called as non-seizure episodes.
So they are seizure mimics. They are not seizures.
Mimics.
Yeah. So they are mimics. They look like
Mimics.
seizures, but they are not seizures. And that's how the
Seizures.
clinical criteria has been taken out, because we are
Yes.
over managing, over diagnosing seizures.
Seizures.
Okay.
Yes.
So for example, can you give me example of seizure mimic?
Seizure
Yeah.
mimic, it can be jitteriness.
1 minute,
Hello.
Anish.
Yes.
Yeah, 1 minute. I just want to let all of you know, I welcome Dr. Harsh sir. Harsh sir has already joined, and sir, you can also participate in the by asking the questions to the Anish and giving your expert opinion during the discussion.
Sure, ma'am. Sure. Thank you so much. Yeah.
Yeah, please go on.
Yeah.
So it can be jitteriness, it can be hyperplexia, and it can be in the form hyperplexia and benign sleep myoclonus.
Okay. So tell me, how would you differentiate jitteriness from seizure?
So the jitteriness is mostly stimulus sensitive. Once you test, there will be the manifestation, and once you try to stop it, it will get stopped, and there will be no EEG manifestation or anything. So that is jitteriness.
Anything related to gaze or eye movement?
There will be no gaze abnormality of gaze or tonic deviation of the eyeball or any gaze movement in jitteriness, but that will be seen in the seizure.
In my NICU, we don't have EEG. We have EEG,
Yes.
but
Yes,
suppose
ma'am.
we don't have EEG,
Yes, ma'am.
and we have a baby with maybe a junior resident saying it is a jittery baby. How do I
Yes.
know these are seizures or not seizures?
You can just go to the baby, and you can first of all you can see for the change in the heart rate and the SpO2. That is the first thing. And then if you can try it, like you can hold the part of the, you can hold the hand, and if the jitteriness, if the episode stop, that you can say that is jitteriness.
What will happen in the heart rate and saturation?
So if it is associated with seizure, it can be associated with drop in saturation and increase in the heart rate
Okay. So there are
or arrhythmia.
tachycardia and desaturation.
Desaturations. Yes.
Okay. And what do you mean by automatism in motor manifestations?
Automatism means, ma'am, that is like lip smacking movement or puckering movement or chewing movements. So that is automatism.
What's the difference between clonic and tonic movements?
So the clonic movement is the clonic movement is uh, flexion followed by extension of a particular limb, which has a both rapid phase as well as slow phase. That is uh, clonic movement, and the tonic movement is only the flexion, the sustained flexion that can be in the form of opisthotonus, retrocoelus, that is like decerebrate or decorticate. So that is tonic movement, sustained flexion.
What's the difference between myoclonus and epileptic spasm?
Myoclonic seizures has like it involves a particular part, and there is very rapid movement, and it has no rapid phase or slow phase. So and involves a particular muscle group. So that is myoclonic, and that
What
has to be differentiated from, yes, sir.
So what is epileptic spasm?
Epileptic spasm are
Infantile spasms?
infantile spasms is, ma'am, mostly like it is due to like
Fish. Was it
pituitary
specs?
phenomena, like
Expect.
it is, ma'am.
Yes.
Hello.
Yeah.
So, ma'am, epileptic spasms are like it has both like it evolves like sometimes the myoclonic seizures can evolve into the epileptic spasms, like infantile spasms that can evolve.
That's okay. Maybe Dr. Hirsch can throw some light on this.
Yeah, sure. So myoclonic seizures and epileptic spasms, they basically technically define on the basis of EMG recording. So whenever your seizures is ongoing or ictal recording ongoing, you have a EMG electrodes also are placed, and you see how the muscle activation is happening. So very sudden shock like contraction, they are usually myoclonic jerks. And when you have a epileptic spasm are slower than the myoclonic jerk. So they have a initial phase and then build up phase and then they go away. So they typically create a rhomboid shape of EMG recording. So there is a beginning, there is a ultimate maximum contraction, and then again there is a deceleration phase. So that we define them as a epileptic spasms. Okay, fine. So all they are a part of seizure pattern, and which is then evolved. Now, whatever the graph you are showing, so now recently this is the ILA classification what they have now revised. So all the neonatal seizures are by definition are the focal seizures. So we don't have now any clinical only seizures. All the seizures are electrographical. They may have a clinical substrate or they may not have a clinical substrate. Okay. So EEG is very important in any kind of a neonatal seizures management from now onwards, as far as if we go by the ILE classification and whatever the algorithm they have put forward. And so CFM monitoring is also helpful in HI related cases. And most of the neonatal epileptic encephalopathies, especially, they are very critical to have a proper electrode, proper EEG monitoring unit, and then you can define properly them, and they can you put out the whatever the conclusive efforts for the diagnosis as well as management part is concerned. Yeah.
So Dr. Anish, what is sequential seizure?
Yeah.
Sequential seizures, like it occurs in the sequence, like it starts from the face, then hand, and like
So you're
sequence.
talking about
Sequential.
Jacksonian march here?
No, ma'am. This non-migrating, not the Jacksonian mark that occur more in the pediatric population. So it is non-Jacksonian malignancy, like malignant epilepsy of infancy that is seen.
So here in
So
sequential seizure, the seizure foci may migrate from one side to another side. That's
okay.
it. Okay.
Okay.
And as Dr. Har just mentioned, tell me, if you are sitting in OPD, okay, you are sitting in NICU, and there is a baby who
Yes.
is referred from outside hospital. Okay. And a senior pediatrician has referred the baby to you, saying that this baby had seizure episode. Okay. Would you consider that baby, the baby comes to you, would you consider that baby to have seizure or no seizures?
Ma'am, if they have a video recording or something, then
So there is no
then we
video
can see.
recording. There is no video
Okay.
recording, but the person says they were focal seizures.
Okay.
Now,
Ma'am, according to to them, we have to consider, but we have to observe, and we don't have to start the treatment at the earliest. We have to first observe and then do the treatment, not
so
start the treatment.
okay, good. So again, as per the recently published guideline, if a senior person has observed seizure, which are focal,
Hmm.
you consider those seizures to be probable seizures.
Yes.
Okay.
Yes.
Or any seizure which is
Yes.
not focal but observed by senior person are possible seizures.
Yes, ma'am.
Okay.
Observed by senior
But
experienced person.
yes, yes. And otherwise, if you do not have, if the seizure has been observed by, person who is not experienced
Hmm.
and they are not focal, then you don't consider those as seizures. You have to evaluate
Seizures.
the child. You have to
Yes.
confirm that they are actually
Confirm the
seizures.
seizure. Yes.
Yeah.
That is
Okay.
the change in the guideline. Yes.
Yes. Continue.
The next thing, that is the brief rhythmic discharges. These are the patterns that met the criteria for the neonatal seizures, that meet the criteria for the neonatal seizures, but are shorter in duration, as we have discussed, of more than 10 seconds. Here it is less than 10 seconds. So these are called as BIRDs, that is brief infantile rhythmic discharges, and it may be associated with the underlying brain pathology, occurrence of seizures, increased risk of future developmental delay, cerebral palsy, and mortality. So now the types of seizures. So the most commonest type, that is subtle seizures. So these are the paroxysmal alteration, the behavior, motor on the and the autonomic function. That is more common in the preterm than the terms. Usually have a EEG correlation, and that in they have a thing for tachypnea, apnea, but there is no bradycardia. So it is the most common type of seizure, and they have a particular phenomena that is seen, that is ocular phenomena, orobuccal movement, and the other movements. So one of the most important type that is seen is tonic horizontal deviation of eyes with or without jerking of the eyes, and the sustained eye opening with the ocular fixation. Orobuccal movements, that is chewing, and the other manifestation may be in the form of limb movement, autonomic phenomena, and the apneic episodes, but not associated with the bradycardia. Clonic seizures. These are repetitive rhythmic jerking movements, rapid phase as well as slow phase, and is the most important seizure associated consistent with the EEG correlation. So again, these are type of focal and multifocal and generalized. So the focal is localized clonic jerking, usually not unconscious and often associated with the EEG seizure. Multifocus, simultaneous or in sequence, that is occurring in the clonic jerking from the multiple location. Non-ordered migration, that is non-Jacksonian and often associated with the EEG seizure. So tonic seizures. Tonic seizures are sustained flexion or extension, but not the both. That is not flexion followed by extension, but it is the sustained flexion or extension of axial or appendicular muscles. So these are focal tonic and generalized tonic. So sustained posturing, asymmetric posturing, and the focal thing is associated with EEG, commonly associated with the EEG thing, but the generalized is not commonly associated with the EEG thing. And other things that can be seen associated with this decelerating, cortical posturing. So the myoclonic seizures, these are rapid, isolated jerks, affect one or multiple muscle groups, arise from injury to any level of the nervous system. These are focal multifocal myoclonic seizure, well localized, single or multiple migrating jerks, usually of limbs, and not accompanied by the electrographical seizure discharge. The generalized myoclonic is associated with the and EEG seizure discharge. So this is the table that shows clinical seizures associated with the electrographical pattern, common or uncommon. That subtle seizures are having a common association with electrographic seizures. Clonic, both focal and multifocal, both are associated with the EEG pattern. Tonic, focal is associated, but not the generalized thing, but can be associated. Myoclonic, focal multifocal has an uncommon relation, but generalized has a common relation, and the no clinical seizures.
It's good to know the type of seizures, but the classification has changed now.
Yes, sir.
Yeah. So you already mentioned the classification.
Okay,
As you written here, this is the classification by Volpe
yes,
in 1989, right?
1989. Yes, ma'am.
Yeah.
Yes, ma'am. So now this is the again with the in line with the 2017 classification of seizures and consideration of for units. These are, as already has been discussed, that is automatism, clonic, epileptic spasms, myoclonic. So what is the things? The automatism is a more or less coordinated motor activity occur when the cognition is impaired. So it is more or less seen in HIE and preterm infants. Clonic season, as we have already discussed, that is jerking, which may be symmetric or asymmetric, repetitive, and involves the same muscle groups, and mostly seen in cerebral hemorrhages. Epileptic spasm, that is sudden flexion, extension, mixed extension flexion of predominantly proximal and truncal muscle, usually more sustained than the myoclonic type. and they are rare and mostly seen in the inborn era of metabolism. Myoclonic, it is a brief kind of seizure that involves a single or multiple contraction cell groups of variable topography. And again, these are the seizures that is seen in IEM.
Okay.
So tonic, yes, tonic, autonomic, behavioralist, sequential seizures that we have already discussed, and electrographic only seizures that is mostly seen in preterm infants and HI and unclassified seizure type. So is EEG mandatory for the diagnosis? So the clinical diagnosis, as we already know, often we, even as a clinician,
I think we lost him again.
Yeah.
Generally, a long form presentation. There are quite a few slides which are there in this presentation. So hopefully it will be useful. I don't know. Questions किसी ने पूछे नहीं अभी तक, I think. Neil madam, कोई questions आए? और Momita, any questions have come in the other platform?
नहीं सर, चैट में तो नहीं दिख रहे हैं, और अदर प्लेटफॉर्म का मैं नहीं बता सकती, वो मोमिता को ही पता होगा.
Yes, sir.
Are there any
I'm
questions?
checking, sir.
Okay,
Till
okay.
now, we haven't received any questions, sir.
Okay, fine.
जो
Anish, you can...
हाँ, जो पीजीज यहाँ पे है प्रेजेंट, एंड इफ दे हैव एनी क्वेश्चंस दे कैन कंट्रीब्यूट. So all the PGs, please contribute in the discussion.
Rohan will not ask. His senior is presenting, so he will not ask.
रोहन के अलावा भी है ना सर, बाकी लोग भी तो है. रजत इज ऑलवेज अ वेरी गुड पार्टिसिपेंट. आज रजत शांत है.
रजत कहाँ से है?
रजत इज फ्रॉम गोवा.
हाँ. रजत प्रश्न विचारता रहे तो विचार मरे. Anish is still not joined. He's got joined and Anish left again.
So Anish left again. डीएनबी वाले बच्चे एग्जाम में जरा बिजी हो गए हैं अभी. 29th इज देयर एग्जाम, प्रैक्टिकल एग्जाम. तो आज डीएनबी वाले बच्चों ने ज्वाइन नहीं किया है.
There he started. Rohan is sharing now. What is happening?
ये ऑनलाइन प्लेटफॉर्म का ये थोड़ा रहता है कई बार सर.
क्या?
जितने एडवांटेजेस है उसमें थोड़े बहुत डिसएडवांटेजेस भी रहते हैं.
If I'm making a presentation, I connect to my mobile phone. That is the most easiest one. If I connect to hospital or home network, ना लाइट चले जाते कुछ होता है, so gets disconnected. I don't know where. अनिश कहाँ से प्रेजेंट कर रहे हो? Again is gone.
अनीश है ही नहीं सर, अनीश नहीं है, रोहन भी अभी तो निकल गया इसमें से। आपके यहाँ पे लाइट जाती है करमसद में?
I don't know why it is happening. ये this must be hospital connection. It does get disconnected. Light नहीं जाती है. ये
हाँ,
hospital होगा. It must be getting
Anish is
disconnected.
back again. I think he needs to connect his computer with two mobile devices.
कंप्यूटर में कर
अनीश कहाँ से प्रेजेंट?
कहाँ चला गया
एक जियो का ले लो, एक वोडाफोन का ले लो।
सर
मेरे
एनालिसिस
ऐसे से कनेक्ट टू द मोबाइल फोन. मोबाइल फोन में नहीं है नेट.
ये सर मोबाइल फोन से किया है अभी एक्चुअली सर
अच्छा.
नेट का इशू है
मोबाइल में भी.
नहीं मोबाइल में नहीं सर अभी मोबाइल से इसीलिए कर दिया
हाँ, मोबाइल से कभी डिस्कनेक्ट नहीं होता है. इफ यू हैव गुड कनेक्शन.
यस अभी आ रहा है
वापिस लेफ्ट।
क्या कर रहा है वो?
कुछ प्रॉब्लम है उसके कनेक्शन की।
I think now he's joined through Rohan's laptop probably. But you'll do EEGs of neonates in the NICU. Like what AEG you'll do? What you'll have?
Yes, we are doing EEG. We have the bedside EEG monitor has got conventional video as well as AEG.
Okay. And how many beds you have? Like with you have one
We have,
bed with
no, we have
EEG?
only one machine, so that is used. Means we do cooling also. So it's there. It's there since last maybe what 8-9 years.
Mhm. And how often do you use it in a month? Like how many patients get?
2-3 patients. Every patient with seizure we start EEG monitoring.
Every
Or
patient?
maybe or severely asphyxiated babies also we start EEG monitoring to pick up HI early.
और कोई करता है? मतलब I don't know if anyone else does it.
I think Pune Bharti has recently started doing it, but they have only amplitude integrated.
No,
We have
we have amplitude integrated EEG, but we don't have regular EEG. उसमें से भी हो सकता है. I think you can get some EEG.
yeah.
HI में sir CFM will be useful, not an issue for this cooling therapy. You can monitor the burst suppression and even the seizures also. But yeah, if you are dealing with the proper neonatal seizures with other etiology, then you might require a proper 32 channel EEG, you know.
So what EEG we have is amplitude integrated, but whenever the neurologist wants to assess it, he can always switch that amplitude integrated to conventional.
Oh, yes, yeah.
Can go through the entire EEG.
उसमें दोनों हो सकता है ना, मतलब CFM में दोनों हो सकता है.
Yes.
So who reads your EEG, Shilpa? In it's your
My
husband only?
husband.
So
My
actually,
husband.
anything sort of calling your husband also. Then I said no, we'll call some other pediatric neurologist.
No, good you didn't call. He's already in one conference, I guess, in Vellore.
I thought then no, I said it's better to have somebody else. Okay, you can start, Anish.
yes sorry for the delay so is the EEG mandatory for the diagnosis so as we all know the clinical diagnosis is very difficult in particularly in the critically ill infant as the motor pathway is immature in both term as well as preterm and in the most common cause that is the HI 50 to 80% of seizures are electrographic. And as a result, the seizure burden some of the time may be underestimated. And as we already know that the phenobarbital as well as the therapeutic hypothermia causes electroclinical uncoupling, and we have already discussed that.
Therapeutic
So
hypothermia leads to electroclinical uncoupling.
yes, ma'am, it is associated with the therapeutic uncoupling.
How
Electroclinical.
how does therapeutic hypothermia cause electroclinical uncoupling?
Actually, the etiology for this I didn't get in the books, but the written thing that I have is that both even phenobarbital as the therapeutic hypothermia can cause electroclinical uncoupling. The mechanism for the phenobarbital is known, but the as I have searched for it, the therapeutic hypothermia, the mechanism for that is not written or not known to me at least.
Therapeutic hypothermia will not cause electroclinical uncoupling. Okay, it's not
Okay.
therapeutic hypothermia. Maybe it is the severity of asphyxia itself, that the tone is so depressed that you may not see HI, you may not see the clinical event. Or babies generally with HI stage 2, invariably they seize. So they are on
Yes,
phenobarbital. So it may be together you're
phenobarbital.
talking about. It's not individually
Okay.
therapeutic hypothermia
Individually.
which causes electroclinical uncoupling.
Okay.
Yeah.
So the seizure burden versus the frequency, when to start the treatment. So the seizure burden, that is the electrographic seizures in a given period associated with the poor outcome. And the rare brief seizure will not require the treatment, but should initiate, if possible, the EEG monitoring. It is recommended that seizure burden greater than 30 to 60 seconds per hour should need the start of treatment. So this is the thing, the baby with high risk of seizure and or the baby with the clinical event, if the EEG is available, that if the EEG is available and if there is continuous EEG correlate is there, then it is a gold standard for the diagnosis of the seizure. But if the correlate is not there, then it can be told as the no seizure. Second thing, if AEEG is there and baby with the high seizure and the baby with the clinical event is there, so the level 2A evidence is the probable diagnosis of seizure. And if AEG is not available, then this has an insufficient evidence. But again, the most important change over here is if the seizure or the clinical event has been observed by the experienced personnel. So if it is yes, then if it is a focal tonic or focal clonic, then it is a probable diagnosis of seizure. And if it's the other seizure type, then it is a possible diagnosis of seizures. So, and if it is not observed by the experienced personnel, then it has an insufficient evidence to call it as a neonatal seizure. So the etiology, as we know, the most important cause here is HIE. That is 50% of the cause is HIE, followed by arterial stroke. Followed by ICH, arterial stroke, intracranial infection, cerebral dysgenesis, or dysencephaly and everything, and IEM. So the causes of the neonatal seizure, when the presentation time is less than 4 days, then we should consider thinking of HIE, acute metabolic disorders, ICH, acute metabolic disorders, maybe in the form of hypoglycemia, hypoelectrolytemia, congenital viral infections, pyridoxine dependency, non-ketotic hyperglycemia, and urea cycle disorders, and early onset sepsis.
What is hypoelectrolytemia?
Ma'am, hypoelectrolytemia is in the form of hypocalcemia or hypomagnesemia that can cause seizure.
Or
hyponatremia.
okay.
So the etiology of seizure, that is, if the presentation time is 4 to 14 days. So the community acquired infection leading to meningitis or encephalitis, community acquired infection leading to meningitis, bacterial meningitis, or encephalitis, that is enteroviral or herpes simplex. Metabolic disorders, mostly late onset hypocalcemia, that is related to the cow milk feeding that usually people give, can lead to metabolic disorder, late onset hypocalcemia, and persistent hypoglycemia. Inherit this IEM, that is galactosemia or fructosemia, and the drug withdrawal and the connectors. So if the presentation time is 2 to 8 weeks, again think of infection, head injury, that is subdural hematoma, inherited disease of metabolism, and malformations of the cortical development. So this is the thing, how the brain maturation occurs in the neonatal life. That is neuronal proliferation, migration, synaptogenesis, programmed death of cells, reorganization of synapses, myelination. All this thing occurs in the newborn brain, which further lead to lack of GTC seizures, asynchrony, and presence of non-motor phenomena. That is again unlike to the adult thing. So this is the pyramid, that is acute reactionary event. It can paroxysmal non-epileptic movements, benign epilepsy syndromes, and the catastrophic epilepsies. So now the diverse etiology, we can go fast through it. All the etiologies that we have discussed. So asphyxia, intracranial bleed, infections, metabolic malformations, and miscellaneous things. So the hypoxia and the ischemia, that is HI. So this is the most common cause. Seizure usually develop within the 6 to 24 hour of life, and this is frequent, severe, and it can be subtle or EEG only seizure or multifocal clonic or EEG only seizures. Second thing is stroke, that contributes to 20%. That again is focal clonic and exhibit relatively few other overt signs of encephalopathy. Hypoxemia, ischemia, that can lead to periventricular leukomalacia, leading to the formation of cyst, and that can lead to the seizures. Now the seizures as a prognostic sign in HI, if it increases the risk of neurological sequelae increased by 40-fold, recalcitrant seizures, that means the seizure that is not responding to the initial first line or second line of treatment, that are associated with death and the neurological deficits. Onset, if it is less than 4 hours, the risk of the adverse outcome increases to 75%. Intracranial hemorrhages, 15% in term and more in preterms. So the most common thing that is seen is intraventricular hemorrhage, that is preterm, less than day 3 of life. It can be focal, multifocal, or it can be severe in the form of tonic seizure. And in catastrophic case, it can lead to coma and as well as the respiratory arrest. If the intracranial hemorrhage occurs in the term baby, it is the most common association is the vitamin K deficiency or the trauma. In the SAH, that is the subarachnoid hemorrhage, the baby will be well and not sick, unlike the grade 3, grade 4 IVH, but can be associated with the seizure. Other thing that can see in the term is SDH, that is the subdural hematoma, that is leading to the focal seizures, and that the onset is less than 48 hours. And the periventricular hemorrhagic infarction occurring more than day 3 of life. Infections, so the meningitis that can lead to the focal infections. Bacteria most commonly associated nowadays in India is Acinetobacter, followed by Klebsiella, followed by E. coli. Non-bacterial, Toxoplasma, CMV, Rubella, herpes, or Candida. And it can be subtle, focal, multifocal, with inflammatory infiltrates and ischemic vascular lesions. And they are notoriously difficult to manage, and it can later lead to the vasculitis, which can be controlled more readily. Developmental defect in the form of lysenscephaly, pachygyria, or polymicrogyria. So the other thing is tuberous sclerosis, that is the most one of the severe form, and it requires treatment, and that can lead to the infantile spasms.
In how many cases tubers are present in brain at birth?
In how many cases?
What is the presentation of tuberous sclerosis in newborn? Is it seizures?
No, ma'am. It is in the sometimes it's the MRI finding that is seen in the form of tubers, or it can be in the form of later stage. It can be in the form of infantile spasms.
Is there anything related to heart that presents?
Rhabdomyoma.
Right, that would be the
Yes,
common
that
presentation.
2D.
Yeah,
Yes.
tubers develop gradually, and by 6
Gradually.
months they may have tubers, but not at birth.
So developmental defects. Clues for that is dysmorphic face, abnormal head circumference. Now the metabolic, that is hypoglycemia, again occurs usually during the second postnatal day, and the duration of hypoglycemia is very significant for the brain injury, and the neurological symptom may be in the form of lethargy, jitteriness, or seizures. And the seizure version hypoglycemia. Hypocalcemia, early onset, late onset. Early onset, it is usually within 3 days. In the cases of IDM low birth weight, preeclampsia, mother taking phenobarbital. So that again causes early onset hypocalcemia. Late onset is most common is cow milk allergy, cow milk giving, maternal hyperparathyroidism, Diderot syndrome, hypomagnesemia, and that are characterized by hyperactive DTRs or exaggerated startle, jitteriness, and that can be in the form of focal seizure also. So as we have told about the hyponatremia as well as hypernatremia and as well as sudden correction can lead to the seizures. Metabolic can be in the form of all of these, but the clues for these are the most often is like baby presenting at the third day of life with on full active feeding with seizure, vomiting. So one of them is the clue. The sensorium will be depressed. It can be in the form of hyperammonemia, lactate can be high, hypoglycemia, acidosis. Again, we have to rule out the IEM and see for it. And one of the most important thing, it can be it is not helped with a treatment of phenobarbital, eptoin, or anything. So sometimes people do give like it is nowadays like in the recent update, if the baby is not getting like not the seizure is not subsiding with the phenobarbital, eptoin, levetiracetam, then if you have like you can give a trial of pyridoxine 100 mg and see to it if it is subsiding or not. So one of the most common metabolic disorder associated with the seizure is pyridoxine dependent seizure. So you have to like if it is not subsiding, you have to give a trial of 100 mg pyridoxine. So these are the causes: non-ketotic hyperglycemia.
Yeah. So how would non-ketotic hyperglycemia present? What from seizure? How do you know that this seizure is NKH?
No idea.
Any EEG characteristic EEG finding?
No, man.
Dr. Hirsch is around. So they are typical brushes, I guess, in NKH.
Brush
And
with-
plus, do they have hiccups?
Yes, sir. Intractable hiccups are the most common manifestation.
How does sulfite oxidase and multiple carboxylase deficiency present?
And multiple carboxylase deficiency and sulfite oxidase deficiency. They are mostly a part of like they involve basal ganglia and everything. So
They will have skin manifestations.
skin. Multiple carboxylase will have a skin pellagra like rash and everything.
And sulfite oxidase would appear like HIE. So sometimes you have biochemical parameter, you do uric acid baseline, not very sensitive, but you do uric acid levels and uric acid levels may be low. Even molybdenum cofactor deficiency for that sake. Okay. How does glutaric aciduria? How do we suspect glutaric aciduria type 2?
No, ma'am. No.
Anything on MRI?
No.
Yeah, hygromas you see on MRI.
Okay.
Okay. What is UCD?
Yes, ma'am. Urea cycle defect, hyperam.
How do they present? They present with seizure or something else?
Urea cycle defect mostly encephalopathy they present, and usually they are identified by increased ammonia levels.
It is hyperammonemic encephalopathy.
And hyperammonemic, so increased ammonia levels.
And how do we suspect mitochondrial disorder?
So mitochondrial disorders are mostly like increased in lactate on the DBG finding lactate will be high, and they have a like if we go for the family tree, it has a maternal inheritance.
And how does this paroxysmal Zellweger present?
And they are long chain fatty acid disorders. So
clinically, how does this baby look like? Zellweger.
No idea. Brown.
Right? Little downish. What about adrenoleukodystrophy?
And these are like the brain में even lesions होते हैं, white matter can involve.
The family history.
Family history. Okay.
Correct? Yeah. So when you're presenting, you need to know that the patient is seizing in front of you, whether this is which kind of metabolic disorder you're likely dealing with.
Yes.
Right. Yes.
So these are metabolic IEM. So now the most important, one of the most common thing that we encountered is bind, that is bilirubin induced neurological damage, that is acute bilirubinoencephalopathy.
What is bind? What is bind? What did you say?
Bilirubin induced neurological damage.
No. Bind is bilirubin induced neurological dysfunction.
Dysfunction, yes, dysfunction. So that causes acute bilirubin encephalopathy, and that can lead to seizures. And the miscellaneous causes pyridoxine dependency, folinic acid seizures, and glucose transporter defect, and local anesthetic injection. Drug withdrawal, most common is methadone. Polycythemia can lead to seizure, and hypertensive encephalopathy can lead to seizures.
In Indian setting, what is the reason for drug withdrawal?
Mother taking methadone and like opiate poisoning and everything, then it can lead.
Do we see opioid poisoning in mother? What is the reason that the baby may go in drug withdrawal?
It is mostly due to methadone and everything. Methadone drug.
They are on antidepressants. No?
Yes, ma'am.
Yes. So sometimes, yeah, they're on antidepressants, and that may cause. Okay, what is the reason for seizures in polycythemia?
Ma'am, polycythemia is like hyperviscosity. So the it can lead to stroke, and further it can lead to stroke is the thing that can lead to the seizure.
Where is this stroke? Polycythemia leads to what stroke?
It can cause like ischemic stroke, ma'am, frontal or cortical level, ma'am.
Polycythemia and hyperviscosity can cause sinus venous thrombosis.
Cerebral
Yeah,
syndrome.
that can cause problem. Yeah. Next.
So next is hypertensive encephalopathy and idiopathic familial syndrome that we will discuss. So this is pyridoxine dependency cycle, and that can lead to early seizures within first hours of life, and in the intrauterine life, increased fetal heart rate can maybe an association thing, and they are recalcitrant seizures, and they are multifocal, and tonic-clonic generalized seizures are very rare, and they are due to the defect of ALDH7A1 gene, and they are autosomal recessive, and cessation of seizure is due to with the help of 50 to 100 milligram of pyridoxine.
What
And
is the
if it is,
intrauterine presentation of seizures?
ma'am, when we do the NST, there may be more of an increase in heart rate, and in the CST there may be variable deacceleration or early deacceleration.
Oh, one thing mother will tell you, and that you will know that this baby fetus may be having seizures.
Excessive movements, ma'am.
Yeah, excessive fetal
Movements. Yes, ma'am.
Yes.
So I have one case when mother was able to count around 80 to 100 kicks within few seconds, because she has a one history of abortion also. So she was asked by the gynecologist to count the kicks, and that was the hint for us to start life with refractory seizures. And these all are the metabolic seizures. The important part is they are not only seizures, they have a profound encephalopathy. So when you have encephalopathy out of proportion to the degree of seizures, always think in terms of metabolic and other etiology. While in rest of the causes, they have encephalopathy when you have HI and everything. But when you don't have any that kind of a significant history and child present with a few episodes of seizures and profound encephalopathy, then the metabolic etiology is more likely to be, keep in our mind.
Okay, sir. So these are neonatal vitamin responsive epileptic encephalopathy. So again, that is glucose transport defect. One of the most diagnostic thing is there will be low CSF glucose and normal blood glucose in the normal blood glucose. So that is called as glycoria. That is low CSF glucose, and onset is usually 2 to 5 months, and the treatment is ketogenic diet. Idiopathic syndromes that we will discuss is, so these are mainly the epileptic syndromes, that is benign familial neonatal seizures and benign idiopathic neonatal seizures. That is also known as benign non-familial neonatal seizures. That is also known as fifth day fits. And the severe one, that is EME, that is early myoclonic encephalopathy. And the second severe thing is EIEE, that is early infantile epileptic encephalopathy, which is also known as Otohara syndrome, and the malignant migrating partial seizures. And the non-epileptic syndromes are the other thing, that is benign neonatal sleep myoclonus and the hyperphagia. So we will see in the differentiating forms of all this, like how to differentiate the seizures. So the benign, that is BFNS, that is benign familial, and benign idiopathic. So the benign familial occurs between second to third day, and the benign idiopathic, as we said, it is a fifth day fit. The most common presentation is the fifth day, that is between 4 to 6 days. And the benign familial is focal clonic and tonic seizures. And these are multifocal clonic, maybe in the form of apnea. And EEG, the EEG is the interictal stage will be the normal. And in this, there is theta 0.0 alternate EEG change will be seen. This is autosomal dominant with incomplete penetrance, and KCNQ2 and KCNQ3 potassium gated channels are involved. And here it is associated with zinc deficiency, self-limited, and within the 15 days. And benign familial is self-limited within 1 to 12 months, and it 10 to 15% have a non-febrile seizure. But the neurological development will be the normal. Initially, what we see in the EEG, in the benign familial neonatal seizure, is EEG flattening, followed by apnea, followed by tonic motor activity, and there may be it may be followed by discharges, like bilateral discharges of spikes as well as slow waves, and can be accompanied by the clonic activity. So the next thing, EIE and EME. So the EME is, as the name suggests, that is myoclonic, focal clonic seizure, tonic spasms, and these are only tonic spasms. Both have same pattern, that is the burst suppression pattern. And in relation to sleep, the EME will be enhanced by sleep, and EIEE is, there is no relation to the sleep. The evolution will be in EME, it will be persistent burst suppression, but in EIEE, there will be hips arrhythmia. And the most common cause for the EME will be metabolic disturbance, followed by cryptogenic or idiopathic, and structural cause. And EIEE, that is structural lesions, are more common, and outcome will be poor in both. Other syndromes that can be seen is like they can be associated with Aicardi syndrome, cerebral atrophy, and migrational defects. And one of the thing is that is DEND, that is developmental delay epilepsy neonatal diabetes, and it is caused by the activating mutation in the KCNJ1 mutation. So unknown is cryptogenic, that is with signs of CNS injury, but the cause is not determined. So now the time of onset, we have discussed all this. So if it is 0 to 3 days and more than 3 days. So HI, as we all know, the seizures for HI will occur in 0 to 3 days. ICH can occur both between 3 and more than 3. Same goes with infections, developmental defects. In hypoglycemia, time of onset usually between 0 to 3 days. And hypoglycemia, again, both other metabolic syndromes between 0 to 3 days. And epileptic syndromes can occur both between 3 days and more than 3 days. So how is the frequency in both term and preterm? So HIE, it is more in term than the premature. ICH is more in preterm than term. Hypoglycemia can be seen in both. Hypoglycemia can be seen in the both. Infections can be seen in both. Developmental defects again both. And other metabolic and epileptic syndromes are more common in term as compared to the preterm. So this is the multiple etiology: asphyxia, preterm, IDM, and infection, cerebral malformation. So what are the non-epileptic movements? So the non-epileptic movements can be in the form of jitteriness, tremors, hyperplexia, that is also called as benign Stiffman syndrome, roving eye movements, sucking and puckering movements. So now how to differentiate, as ma'am already asked about it. So we will now see what is the difference between jitteriness and seizure. So if abnormality of gaze or eye movement, as ma'am asked, it is more common in seizure and not in jitteriness. Not seen in jitteriness, seen in seizures. So stimulus sensitive is jitteriness and not seizure. And the predominant movement, that is in jitteriness, it is tremor, but in seizure, it is clonic jerking. And movement cease with the passive flexion in jitteriness, but not in seizure. And autonomic changes are more common in seizures. Now, benign neonatal sleep myoclonus and hyperplexia. So the benign neonatal sleep myoclonus will occur in the NREM sleep, and it is provoked by the rocking movement, gentle rocking movement, and can be stopped by like gentle restraint and arousing the baby. But the EEG will be normal and is exaggerated by the benzodiazepine, and it will resolve within 2 months. Now the hyperplexia, that is also called as Stiffman syndrome. There will be an exaggerated startle response. It can start with a few days in utero, and autosomal dominant in relation to the chromosome 5. EEG will be normal and caused by the glycine receptor mutation. Clonazepam can be used, and the episode ceased by the 2 years. So now we will move on to investigations. So investigations, as like more important is like we have to identify first of all, and then we have to investigate. So the essential investigation and the additional investigation. So as soon as we know the baby is seizing, so we will first do for the blood sugar and send for the like calcium, and then any baby who is seizuring, we have to do CSF examination until unless the seizure is caused by HI. If you think like seizure is causing by HI, you can, or there is abnormal Apgars and everything or base deficit, you can avoid doing CSF. And if you have a
Hold on. So CSF is mandatory in all seizing baby?
until if it is there is like a CSF can be withheld only in like HI baby, or if there is like if otherwise we have to give like we have to do CSF because most common is like infections. So infections leading to meningitis. So CSF is mandatory.
In
Otherwise,
Indian setting, we are also talking about HI as one of the one of the manifestation of infection.
yes, ma'am. But if we have a thing for like if we have abnormal Apgars and everything in hand, like if it's an inborn baby, abnormal Apgar base deficit, and if we are labeling clinically HI, then and baby is seizing within the time period of 6 to 24 hours, then we can avoid doing CSF. There is no need to do CSF.
CSF, as you are rightly talking about, definite HI CSF is not needed.
Not needed.
Similarly, if there is no clinical suspicion of sepsis, CSF is not required.
Not required.
Okay, CSF is not mandatory, right?
Not
A
mandatory.
well-appearing baby coming from home and 4th and 5th day seizing, you do septic screen, it is negative. You don't have to do CSF. It is not mandatory. Okay.
Okay, ma'am. Yes, ma'am.
Could be hypocalcemia, could be hypoglycemia.
I mean, it is all yes. If it is like if you do have rule out the cause of hypocalcemia, calcemia,
No, still, if there is even
then
cerebral
we
malformation,
we
you don't.
could
So
go
if
for
there is no
CSF.
clinical setting for sepsis, you don't have to do CSF. Okay, that is a
Okay, ma'am.
WHO guideline. CSF to be
Okay,
done
ma'am.
only in case of clinical setting of
Clinical
sepsis.
setting. Okay, ma'am. So other additional investigations, that is hematocrit, serum bilirubin, magnesium, arterial blood gas, and iron gap to see for the IEM. Imaging is CT MRI, torch screen, and workup for the inborn error of metabolism.
You would do all these investigations in a seizing baby?
No, ma'am. We don't do.
How would you proceed
all.
with the investigation?
So, ma'am, if we know like baby is HI, then we don't go for CSF.
Tell me, a baby is seizing in front of you. How
Yes,
would you
ma'am.
proceed with the investigation? The baby has come from home. You don't know the baby is in front of you seizing.
Yes, ma'am.
How would
We
you
will.
proceed with the? It's a
Okay, ma'am.
4-day-old baby.
4-day-old baby. So we will go for random blood sugar. We will go for random blood sugar, and we will take the sepsis screen, and then we will start with the treatment, and then we will wait for the septic screen to come, and then we will decide for the CSF.
No need for ionic calcium, magnesium, sodium,
Ma'am, that
potassium.
will BBG like we will send us that screen that BBG will contain ionic calcium.
So how is the correlation of VBG with actual baby's electrolytes?
We will like BBG actual correlation with electrolytes we send separately. When BBG septic screen electrolyte we will send, but not ionic calcium. Ionic calcium we have in the like BBG thing only.
Is it correlated well with the baby's ionic
Yes, ma'am.
calcium?
Ma'am, like in the like BBG is correlated well. At least in our settings, I know like if ionic calcium
What
is around.
series? How are you collecting VBG?
Yes, ma'am.
It's not like that. So if your method of collection is correct, if you're using pre-heparinized,
Yes, ma'am. Pre-heparinized. Yes, ma'am.
okay, in the standard machine,
Yes,
and if you're processing the gas
Fine.
normally, then only you can say it correlates. But
Yes, ma'am.
in seizing baby, in a baby who is seizing, I think better to go for lab investigation,
Okay, ma'am.
right? Because
Yes,
that
ma'am.
that could be one of the reason.
One of the reasons.
Yeah. So,
Yes, ma'am.
so it's always better to go for lab confirmatory investigation.
Okay, ma'am.
Okay. What do you want to do? Ionic calcium or total calcium here?
Ma'am, ionic calcium is more important over here.
Okay.
Yes,
So you
ma'am.
would do a CBC, ionic
Uh,
calcium,
CBC,
magnesium.
ma'am, magnesium actually we don't do at first. We don't
Okay.
do. Yes, ma'am, we don't do
Okay.
first.
But what is the recommendation?
Ma'am, we should
Do or
do.
we should not do?
We should do. Calcium, magnesium, we should do.
Okay. So ionic calcium, magnesium, CBC, glucose
CBC,
levels,
glucose
and
levels,
septic screen.
septic screen.
That is
Yes, ma'am.
CRP, blood culture,
Blood culture.
right?
Yes, ma'am.
Okay.
We take it this much.
And what about the rest of the investigations you mentioned?
Rest of the investigations, ma'am, like hematocrit, ma'am, we will get in CBC only. So we don't send particularly for that. And serum bilirubin, if clinically we see, if we are thinking of connectors or if there is a like sign or something, then we will send. Otherwise, other investigation we don't do.
How many hyperbilirubinemia patients you have seen convulsing?
Hyperbilirubinemia, ma'am, in last 1.5 years, hyperbilirubinemia patient convulsing, and like I have seen connectors patients, sorry, hyperbilirubinemia convulsing only two patients, ma'am. 2 to
Convulsing?
3.
They were in encephalopathy or they were convulsing?
Convulsing, they were convulsing, ma'am, proper convulsing.
Okay.
Out of like 8 to 10 in which we have did exchange, 2 were convulsing and otherwise all were like in or
Okay.
encephalopathy or in the normal state.
What about the metabolic workup? You would send metabolic workup
No,
right away?
no, we don't send actually. We don't.
So
Right away.
the first line investigations, second line investigations, and third line investigations.
Yes, ma'am.
So your first line investigation is going to be the basic investigation, which you know that you're going to get the report immediately, and that is going to affect the baby's management, right?
Management, yes,
So
ma'am.
that is CBC, electrolytes, ionic calcium, magnesium,
Magnesium.
glucose.
Hmm.
Okay, and then you start simultaneously EEG monitoring.
Yes, ma'am. We have AEG, so we start. Yes, ma'am.
Right. Yes.
Yes, ma'am.
And then SOS, you can plan further management because by that time you would know the history in detail.
Yes, ma'am.
You would know the chronology in detail.
Chronology in detail.
And you must have been done investigation, the baby's clinical examination also. So
Yes,
you
ma'am.
would reach some probable diagnosis and then you would plan the second and third line
Second,
management,
third line.
right? Yeah.
Yes, ma'am. So additional investigations. So imaging, and we go for ma'am neurosonogram to see for IVH or anything. Yes. So that is an excellent tool for dissection of IVH and parenchymal hemorrhage, but not for SAH and SGH. CT scan we usually don't do, and MRI we do in the later stages if and all it is required. And EEG we do AEG monitoring. Continuous EEG has it has both diagnostic and prognostic role. Previously we used to do continuous EEG, but nowadays we are only doing AEG.
EEG is mandatory.
Yes, ma'am. CEG is mandatory, gold standard.
CEEG, what is CEEG?
Conventional EEG or continuous EEG.
So AEG or conventional EEG. So AEG and conventional EEG. So it is mandatory. Okay, in all babies who are seizing or you're suspecting seizures.
Yes,
until how much time you should monitor EEG?
Ma'am, until minimum for CEG minimum 24 hours we have to monitor, and at least 24 hours after the baby is seizure free we have to do EEG.
So in these patients, sonography you can do it. Lots of information sonography can give you. Okay.
Yes,
CT scan is not recommended.
Not recommended. Yes, ma'am.
Not at all. Okay.
Yes, ma'am.
So in case if any neuroimaging is required, then you go for MRI.
MRI. Yes, ma'am.
Yeah. Yeah.
Yeah. So utility of CEEG, that is for confirmation of seizures and unwanted use of AEDs, anti-epileptic drugs, identification of the silent seizures, help to detect the electroclinical uncoupling, help in discontinuation of AED after resolution of symptomatic seizures, and useful for prognostication of neonate with seizures with certain background abnormalities, that is burst suppression pattern, low voltage pattern, or electrocerebellar inactivity. And screen for congenital infection, TORCH, VDRL in cases of hepatosplenomegaly, according to your history and everything. So metabolic screen, TMS, urine GCMS, blood and urine ketone, NH3, anion gap, and lactate.
Which congenital infection is likely to cause seizures? Rubella is going to cause seizures?
No, ma'am, rubella is not going to cause seizures.
CMV will lead to seizures?
CMV and toxoplasma can lead to seizures, ma'am.
What is one infection which can lead to seizures?
Herpes.
Herpes,
Herpes.
right? So you
Hmm.
don't go for torch, the entire torch group.
Yes, ma'am.
You can specifically, you can order one investigation. Okay.
Yes, ma'am.
Why VDRL?
And VDRL in causes like in syphilis and everything, we can like in the second phase it causes like in second stage of syphilis it can lead
Yes.
to.
So you feel it's going to cause seizures, neurosyphilis?
No, ma'am, not much. It is like complete thing, but not it does not cause seizures.
So more than congenital infection, I think your metabolic screen should come up, right?
Compass. Yes, ma'am.
Yeah.
Hmm.
So
Yes, ma'am.
yes.
Hmm.
So metabolic screen. So in which all cases you would do metabolic screen?
Usually, ma'am, if the baby, like if baby was perfectly fine, and suddenly on the like third day, full BF or full RT feeding, suddenly after third day, fourth day, baby started like vomiting, and we have like seizure, vomiting, or anything. Like we have the things, and in the BBG, we are getting something like high lactate or something. Then septic skin is normal and we are not getting any cause, then only we do for TMS. Otherwise, we don't.
Okay. Why urine ketones?
Ma'am, urine ketones are like we do simultaneous like blood and urine ketone both, though it is not necessary. But
It is necessary. It is necessary to know whether it's a ketotic
ketonuria,
hypoglycemia or non-ketotic
non-ketotic
hypoglycemia,
yes,
right?
ma'am.
Okay.
And lactate and anion gap.
We
So-
have some questions in the chat box. I don't know whether it has been covered up or not. I was out for some time, that's why. So, should I go with questions?
I don't know.
So, how IDM causes hypocalcemia? That was one question from Dr. Rajat.
Hello.
Yes.
Hello?
How does IDM causes hypocalcemia?
IDM can cause polycythemia, which can further lead to hypocalcemia. So one of the thing is that IDM is related to polycythemia, leading to hypocalcemia.
So, the reason is that the babies, infants of diabetic mothers, okay, may lose magnesium, right, in urine. So that's why magnesium is done in IDMs,
IDMs.
right? So this can lead to delayed rise in PTH. Okay, so that's how it may lead to hypocalcemia. That's why IDM are prone for hypocalcemia. Okay,
Yes,
magnesium is required for PTH to increase. So hypocalcium is going to stimulate PTH, right? And then again the calcium is going to be normal. So the magnesium is important for that, for the calcium sensing receptor. Right?
Okay. Yes, ma'am. And the another question from Dr. Ravit Patel, that bind affect basal ganglia and the seizures mainly start in cerebral cortex. So what is the reason for conversion in the bind?
Yes, Dr. Anish.
Yes, that is correct. That bind causes like bilirubin deposition in the basal ganglia, and it like the connection with the basal ganglia is with the thalamus and the diencephalon. So that can lead to like the connection that is there, and the myelination that is in the premature or like in the neonates is more in the spinal cord and in the brain stems. So that's why the seizures occur.
No. The question is that seizures are generally cortical in origin. The bilirubin has a predilection for the basal ganglia.
Ganglia.
Why seizure is a manifestation, as the bilirubin is not damaging the cortex. So the question is, thank you so much for that question. So conversion is not a common manifestation of bilirubin encephalopathy. It is a rare manifestation. Generally, the cause is these babies may have other insult, coincidental. So it may be HI, it may be associated with other the metabolic abnormality that may cause seizures. So it may not be a cause for seizure. Yes?
Hello.
Yeah.
Hello.
Yeah.
Am I?
Yes, yes.
अरे यार, इसमें
Yeah.
इसकी नहीं इसमें
And
देखना।
one more question from Dr. Nihal Rahim, that how are the electrolytes correlated with their value on a VBG? A very common doubt among the residents.
So in VBG, like if it is the machine is like properly, and if you do if you take in the pre-heparinized syringe, so and if you process it immediately, so the electrolytes usually sodium and potassium, like in like there is of like a 3 to 4 difference. Like if the VBG sodium is around 147 and 147, so there is plus minus 4. Like in electrolyte, we get around 151 or 153. But ionic calcium is more or less correlated with the VBG or ABG thing, if it is processed immediately and taken with the help of pre-heparinized syringe.
Ideally, ABG is done and it is recommended. So whenever you want to use VBG or ABG for, to know the electrolytes, to correlate the electrolytes, you need to have your own data on the machine what you're using, on the way that you are sampling the blood, and it has been, processed further. So it doesn't accurately correlate with the actual this thing. So when there are outliers on blood gas, you need to confirm it with the lab. Okay. Or if
Yes,
the lab doesn't correlate with the baby's clinical status, the venous sample doesn't correlate with the baby's clinical status, then also you need to confirm with the lab. Okay.
yes, ma'am.
Thank you so much, Madam and Anish both. So you
Thank
can
you.
go continue, Anish.
So other investigation is AEG, that is the portable machine, and the bedside investigation in the NICU, which is easier to apply and interpret. And the background abnormalities like burst suppression, continuous low voltage pattern can help in prognosticating the infant with seizures. And but the the challenge with this, many a times even the neonatologists are have difficulty, have less confidence to interpret. So it may underestimate the true incidence of the electrographic seizures. So AEG is a complementary tool to the conventional EEG monitoring, which always remains the gold standard. So how to prognosticate the seizures? So it depends on the relation to EEG, and it depends on the relation to the neurological disease. So depending upon the neurological disease, how much chances there will be how much percentage there will be a normal development. So if it is HI, so the normal development percentage will be around 50%. If it is IVH, not talking about grade 1 or grade 2, talking about grade 3, grade 4 IVH, the normal development will be 10%. If it is SAH, so the normal development will be around 90%. And in hypocalcemia, early onset, the normal development will be 50%. In the late onset, it is 100%. The baby will be normal in the future. Hypoglycemia, 50%. And the bacterial meningitis, the normal development will be 50%. When there is a developmental defect like pachygyria, lysencephaly, the chances of normal development will be nil. So according to the EEG background, if the EEG background we are getting normal, then the neurological sequelae will be of less than 10%. If there is severe abnormalities, then the sequelae will be around more than 90%. And if the moderate anomalies, the sequelae will be around 50%.
So in short, babies, if any seizure baby, if you come across any seizure, you want that baby to have late onset hypocalcemia or subarachnoid hemorrhage because it has got good outcome. You don't want that baby to have developmental defect because the chance of baby being normal are very
Normal,
more.
very low.
Also, you expect baby's EEG background to be normal, right?
Yes, ma'am. Yes,
Just for the simplified and to remember everything.
Yes, ma'am.
Okay.
So how to approach, as ma'am already asked, how to approach an infant with seizures. So taking a complete history, asking for the video, asking for the day on which the seizures occurs. Antenatal history, you can ask for the movements in the movement count, history of intrauterine infection, narcotic addiction, a history of sudden increase in movements, that is intrauterine convulsions, And perinatal history you can ask, and that is the asphyxia is the most common cause of the neonatal seizure, and detailed history should be taken. So, and feeding history is also important. Clinical features like lethargy, poor activity, vomiting, that is suggestive of IEM. Late onset hypocalcemia, you have to think of top feeding with cow milk. Again, for the family history, you can ask for the consanguinity, family history of seizures, ID, or neonatal deaths. You can suspect for IEM. So examination, you have to go for vital signs, you have to go for general examination, CNS examination, complete neurological examination, and systemic examination. So now the updates on treatment of neonatal seizures. So this is ILE task force on neonatal seizures. So what was the aim? So it has a 6 top priority questions. That was like, which is the first line ASM? ASM is anti-seizure medication. Which is the second line, and how much duration it has to be given, and what is the impact of therapeutic hypothermia on the seizure burden in the HIE infants? What is the impact of electrographical seizure treatment on outcome? And what about the administration of pyridoxine? So the 2022 ILE classification of epilepsy syndromes, they have also included with the epilepsy syndrome, that is KCNQ2 DEE, pyridoxine dependent, and pyridoxamine 5-phosphate dependent epilepsy. So the recommendations. So what is the first line anti-seizure medication? So the evidence-based recommendation was showed that in the baby which requires be the first line ASM, that the phenobarbital should be the first line ASM regardless of the etiology. Only if you are suspecting some channelopathy, then you have to think for phenytoin or of carbamazepine. So the level of agreement was high. So it mainly compared with the efficacy, that is with levetiracetam, that has very low efficacy in controlling the seizures, but the side effects that is more seen with the phenobarbital as compared with the levetiracetam. But the control of seizure was best with the phenobarbital. So these are the evidences that we have. This was the RCTs that was done. Like there's a site from where you can download the RCTs. So that has an overview of all the results, and they have told about how much studies they have given, and what are the, like they have done the grade analysis, and then their studies they allocated are 46, and the study included for the full text review was 11, out of which 2 were the RCTs, and they have applied the grade 2 analysis, and then they have compared phenobarbital, phenytoin, and levetiracetam. So as I have already told, the efficacy with the phenobarbital was much higher as compared with the levetiracetam, and but the side effects are more with phenobarbital as compared to the levetiracetam. So that is highlighted in this slide. So to determine the etiology, five additional questions were included, and the result included that irrespective of the etiology, phenobarbital should be the first line ASM. And if the channelopathy was the etiology, then only go to the phenytoin or carbamazepine. So the first question answer was solved in this. So the first line therapy, again the same thing. Now, what is the second line anti-seizure medication? Previously, it was like line wise, like we used to do like if phenobarbital has no effect, we used to go to phenytoin, then levetiracetam. Now they have like cut down all the things, and they have told once it is not controlled with the loading doses of phenobarbital, switch over to you can switch over to any of the drug like phenytoin, levetiracetam, midazolam, lidocaine. They can be used as may be used as a second line ASM for most of the etiology, and the level of agreement was moderate. So this was the thing. And if again same channelopathy was if the channelopathy was the etiology, then go for the phenytoin or the carbamazepine. And in the neonate with cardiac disorders, the best and the preferred choice was levetiracetam. So again, these are the evidences. Again, grade analysis was applied. for all the studies, and 22 studies were included where they assessed for the levetiracetam, phenobarbital, phenytoin, midazolam, lidocaine, everything. So second line therapy. So if same thing, the neonate with cardiac disorders, levetiracetam was the preferred as the second line ASM. And so second question was solved. The third question was how much duration you should give. So this was like if once the cessation of the seizure is done, like acute symptomatic seizure, without the evidence of the neonatal onset epilepsy, anti-seizure medication should be discontinued before discharging home, regardless of the MRI EEG findings. Previously, what we used to do, like even in the AIMS protocol and everything, still it is there, like we have to do EEG examination, neurological examination, and then we have to decide for the like giving phenobarbital at home if neurological examination is abnormal, and then we have to see. So but now it is like a anti-seizure medication should be discontinued before discharge home, regardless of the findings.
Regardless of the EEG findings, what do you want to say here?
मैम EEG findings मतलब like जो like if it is a like high voltage peak, like showing the seizures, like showing seizure pattern but not background abnormalities like burst suppression, low voltage, in all that cases, like EEG find, if that EEG finding is there, then we have to continue the treatment. Otherwise other EEG findings we have to like just give the phenobarbital in the acute symptomatic phase and then stop it before discharge home.
Harsh, can you throw some light on this? Dr. Harsh?
Yeah, so I think this newer guidelines, they told that irrespective of the even the clinical findings, even abnormal CNS examination, you can discontinue the anti-seizure medication at the time of discharge. As far as EEG finding, they don't elaborate the detail. But even what we have seen in our experience also, even though there is a burst suppression on the EEG or discontinuous pattern persistent, then the chances of having epileptic spasms are very high. But even your continuation of phenobarbital or even suppose levetiracetam or whatever anti-seizure medication, they are not going to prevent the occurrence of this epileptic spasms. So at the end of the day, it is wiser to discontinue the treatment until unless you are definitely dealing with neonatal epileptic syndrome. Then only you are justifiable to start or continue the anti-seizure medication. Otherwise, any kind of a symptomatic seizures, definitely you can stop the medication at the time of discharge.
We don't want to see electrographic seizures on EEG, right? So besides that, anything you find on EEG, you can stop
it.
AED.
So the third question was duration of ASM treatment, that is done. So termination of ASM again, following cessation without following cessation of acute symptomatic seizure without evidence for the neonatal onset epilepsy, ASM should be discontinued. That the previous guideline was if there is seizure free, the previous guideline as by WHO ILAE, if the seizure free period is for more than 72 hours and with normal neurological examination, only then we used to discontinue. But now this has gone, and irrespective of any finding, we have to discontinue the phenobarbital. So now the impact of hypothermia on the seizure burden. So the therapeutic hypothermia may reduce the seizure burden in the neonates with HIE. However, the impact of therapeutic hypothermia as a specific seizure therapy was not assessed, and therapeutic hypothermia may reduce the seizure burden in neonates with HIE. So these are the studies that has allocated. Now the association between the electrographic seizure burden and the outcome. So previously it was like people used to treat only clinical seizures, but treating neonatal seizures, including the electrographic only seizures, achieve a lower seizure burden, and it is associated with the improved neurodevelopmental outcome and reduction of the subsequent epilepsy. So you have to treat the electrographic seizure also. So again, this is the grade analysis. So these are the RCTs that have taken CEs.
Lost.
Again, the problem with the internet.
So the longest he spoke, I think.
This was the longest.
Then we are
So
towards
maybe
the other 10 slides probably. So that's why I said it would be better to interrupt in between and discuss questions. Are there any questions?
Sir, two more questions. How long do we monitor the EEG? And was not clear. That was not clear.
Hello. Hello.
Can I
yes.
answer?
Hello.
How long do we
Yes.
monitor before we start?
Anish,
Yes, ma'am.
so can you answer this? How long do we monitor the EEG? That is one of the question.
Yes, ma'am. So, if you are using AEG or CEG, so minimum of 24 hours you have to monitor, and once the baby is seizure free, then after that 24 hours you have to put on like you have to keep the EEG and monitor for next 24 hours, and then see the EEG pattern, and then you have to see for stopping the EEG and the treatment.
And one more question. Up to what age can we consider phenobarb as the first line? And above what age phenytoin or levetiracetam should be considered first line?
So, ma'am, in talk with neonatal seizures, so the first line treatment always and always is phenobarbital only, and in pediatric age group I think after 6 months or something, we can go for lorazepam as the first choice, lorazepam, or like if the baby is convulsing or in the status, then we can go for lorazepam or directly to the first line of midazolam. But in neonate, phenobarbital will always be the first line.
So in animal model, phenobarbital for first 3 months has shown to be okay. Does compared to any other AED does not cause the neurocognitive impairment. So up to 3 months, I think we can continue and we can manage accordingly. But beyond 3 months, and we have to follow the protocol of pediatric epilepsy.
In general, all the anticonvulsants will cause what is it called? Programmed
Neurocognitive
Neuroapoptotic effect.
neuroapoptosis.
Neuroapoptosis.
One of them will cause, and so phenobarb has been used for many years, but there were not many studies or RCTs which showed that phenobarb was very useful. I think recently in the last 10 years there have been studies between phenobarb and levetiracetam, and they found that phenobarb was much better, and I think side effects were more in levetiracetam, if I remember right, slightly.
Side effects.
So,
so side effects are still more in phenobarbital only.
No. The longest phenobarbital is the drug which has been studied longest.
It has been studied the longest.
Yeah. So the maximum, whatever we know in detail, is about phenobarbital, not about any other ASM, right? So same regarding neuroapoptosis, the maximum data what we have is on phenobarbital. So phenobarbital is still safe for because we don't have the safety data on other ASMs. So and that is studied at least up to 3 months. It has been said to be you can use it safely.
Yes.
So can you change your display settings, because we are seeing both your current slide and the next slide. Display settings.
चला जाएगा. So now it is
Perfect.
So treating electrographic only seizure, as we already told, the experts have agreed to the treatment of electrograph only seizure to lower the seizure burden as well as to improve the neurodevelopmental outcome. So now the treatment is with pyridoxal and pyridoxal 5-phosphate. So after all, like treatment with everything, if there is nothing is working, then trial of pyridoxal has to be given, and neonate, and otherwise if you have a clinical features and EEG characteristics suggestive of the vitamin B6 dependent epilepsy, then you have to give a trial of pyridoxine. And seizures unresponsive to the second line ASM without an identified etiology.
How is it given?
Yes, ma'am.
How is pyridoxine given?
Ma'am, 100 mg trial.
Oral, IV?
Ma'am, oral we can give.
Oral 100 or IV 100?
IV is 100, oral IV is 100, ma'am. IV is 1500.
Is IV pyridoxine available?
IV pyridoxine, yes, ma'am, available.
No, it is not
Hmm.
available. So
नहीं,
we give
okay.
MBI, अपना Neurobion
हाँ मैम
और
भी है
जो भी
न्यूरोबियन देते हैं
Neurobion नहीं,
40 yes
but the multivitamin जो भी available है, so we give
Okay.
that. So we calculate the dose and
Optineuron
accordingly we give.
contains this thing,
Yes,
100 milligram.
Optineuron, Neurobion. Yes.
And the good thing is that even sometimes 100 milligram may revert seizures or improve encephalopathy. Then good thing is that you give 30 milligram per kg per day trial for 5 days. That will be more reasonable protocol to have whether there is efficacy, to see clinical efficacy or not. If at all you are very, clinically very sure that could be pyridoxine dependent epilepsy, then along with IV, if you are not getting that result, you can go for oral 5 days trial and then you can decide.
ये रुक गया मैं उनको बोलो कॉल नहीं करें हेलो हाँ सर हेलो हेलो हेलो
Yes, yes.
okay am I audible
Yes, yes, you are audible.
okay ma'am. So trial of pyridoxine we give and the patients present with myoclonic jerks, spasms, abnormal eye movements or grimacing or EEG characteristic, that is burst suppression pattern, and neonatal seizure unresponsive to the second line ASM, we should try for pyridoxine. If there is non-response to pyridoxine, pyridoxal 5-phosphate can also be tried. At least 3 to 5 day trial should be given to identify the late responders. So the need for the standardized treatment pathway, that is ILAE to 2023 consensus, reinforce the need for seizure management pathways in every neonatal unit, and the parents should be counseled and informed about the cause, nature, options, and likely duration of treatment and possible adverse effects of the treatment. And the clinician should ensure that the same should be documented in the medical notes as well. So this is the thing: if there is seizures in neonate, EEG or AEG confirmed, if not available, clinical diagnosis. First line ASM will always be phenobarbital. Bolus can be repeated, and if there is history of channelopathy, if there is family history of channelopathy, or you are suspecting channelopathy, give phenytoin as a first line or carbamazepine as a first line. And the second line ASM, we have a plethora of drugs from which we can choose. That is phenytoin, levetiracetam, midazolam. So levetiracetam levetiracetam should be used in cases with the babies with hypotension or with any cardiac disorder. So these were the changes from 20111 guidelines that we have almost discussed, but we will go through it. So so the questions are there and the guidelines that have been revised. So the which newborn requires ASM, as the ma'am already said, that all electrical seizures with or without clinical correlates need to be treated, and clinical seizures terms has been gone. So should we treat the EEG seizures? So it is yes. Which is the preferred first line ASM? So the first line is phenobarbital, and if the family history, then we go for family history of channelopathy, then we move to phenytoin or carbamazepine, which is the preferred second line ASM. Again, we have a plethora of drugs already discussed. If the newborn has seizures and controlled on ASM, when should be the medication discontinued? So it should be discontinued before discharge, irrespective of MRI or EEG findings. If the newborn has seizures and is controlled on current ASM, how should be the medication be discontinued? That again we have discussed. So role of prophylactic treatment with ASM in unit with HI. So no role of prophylactic ASM. What is the value of EEG? So they have a stronger role of EEG or AEG in diagnosing seizure. So trial of, and other question, role of pyridoxine. A trial of pyridoxine should be given if you have EEG features, if you have clinical findings, if you have no response to the first line or the second line drugs. So does the therapeutic hypothermia reduce the seizure? Evidence, again, we have got a weak evidence in the TH that it reduces seizure burden. It did to reduce the seizure burden. So these were the questions. So this is the management. So as soon as the baby is convulsing, ensure the TABC, IV access, check blood glucose, serum calcium, correct hypoglycemia, hypocalcemia, and if present or suspected. And again, these are the treatment. Start with phenobarbital. See for the response. Again, if it is not subsiding with 20 mg per kg, go to 10 mg per kg. You can go other 10 mg like 2 times loading you can give. If not responding, again, and then go for the phenytoin, levetiracetam, or midazolam. Levetiracetam in the cases of cardiovascular patients, you can start from 20 mg per kg per day per dose and can reach up to 80 to 100 mg per kg per dose. And midazolam, you can start with 150 to 200 microgram per kg and start with the maintenance. And if again seizures are not, yes, ma'am. Yes, sir. Hello.
So this is like an old this 2015. This is like an 2015 paper. So has this changed considering that new guidelines have come, or it is the same?
Sir, actually,
Lidocaine is there, no? It's second line.
yes, sir. Yes, sir. Yes, ma'am. Lidocaine is there in the second line.
What else is changed in management? After
Ma'am,
second line, you rule out you give pyridoxine challenge.
pyridoxine. Yes, ma'am. That is there.
Yeah. And
Yes,
then
ma'am.
maybe you can go for midazolam trip and thiopentol coma.
Thiopent. Yes, ma'am. Again, it like if it is not considered, like if it is not helpful with seizures are not subsiding with pyridoxine, then pyridoxine phosphate. Again, after that, you can consider for polinic acid also. So
Yeah.
So this was the thing, is if the pyridoxine has no effect and you go to the pyridoxine phosphate, again, if the seizures not respond to it, then go to the polinic acid. And seizures, and if there response, if there is a response, then they are called as polinic acid responsive seizures. So that was the update on treatment. Thank you.
Excellent presentation.
Thank you, ma'am.
Yeah, very nice presentation. One last question from the group is, can you please explain about topiramate role in HI-induced seizures while on therapeutic cooling?
So there are many drugs that have come in like argan, xenon, topiramate, but still the like data is insufficient to say to start with topiramate or not.
Can you stop the presentation?
Okay. Yes, sir.
Topiramate is promising when it is used for neonatal seizures in therapeutic hypothermia. It's a sodium and calcium channel blocker. So,
Yes.
but as you mentioned, there are safe studies which have shown safety of safety profile of using topiramate for babies undergoing therapeutic hypothermia, also for neuroprotection.
Yes, ma'am.
But I think systematic review has been it's not yet published. It's in pipeline, so we will have the results soon. But yeah, we don't have enough data on the recommendation.
Yeah. Ma'am, one more thing. Is there any change in the guideline that no requirement of maintenance if required only single bolus of phenobarbital? So is it same or guidelines changed?
Nish, what's the recent guideline?
So the guideline is if you are starting with the bolus, like you have given the phenobarbital bolus. So usually you have to start after the 24 hour of the bolus.
It is not a bolus.
Loading dose.
Loading dose.
So if you give the loading dose, you have to wait for 24 hours. then you have to decide. So in like if after 24, if within 24 hours there is no effect or like no seizures happening, you can wait for the phenobarbital to start as maintenance. Otherwise, there are chances there will be like prolonged respiratory depression or like the toxicity of the like the adverse effect of the phenobarbital, that is sedation is there. So you have to decide before starting it as maintenance after
If the
24
baby
hours.
is seizing, if the
Hmm.
baby is seizing and you start phenobarbital for that baby,
Yes, ma'am.
when are you going to assess that baby for the effect of phenobarbital?
Ma'am, if you have given given the loading dose, after that, if the seizure subside, then till 24 hours we have to assess for it before starting it as maintenance.
If they don't subside, so if I have given
Hmm.
loading dose now at
Yes,
7
ma'am.
o'clock,
Yes, ma'am.
now it's 7:15,
Yes,
and the
ma'am.
baby is still seizing,
Yes, ma'am.
what do I do next?
So, ma'am, if still we have to wait for 20 to 30 minutes to see for it, and then we have to go for the second loading, that is 10 mg per kg.
So we wait for 15 to 20 minutes and then we
Yes,
go
ma'am.
for second
Second
loading.
loading. Yes,
Yes.
ma'am.
And then if there are no seizures,
Hmm.
then we assess the baby
Yes,
for
ma'am.
24 hours.
24 hours.
There are no seizures, then we switch to maintenance or we don't give any medicine.
Ma'am, usually like 24, if there is no, we don't go with the maintenance.
Okay.
Because phenobarbital, considering its toxicity, we don't go with the maintenance.
Yeah. So you may or you may not.
May not.
So
Yes,
there is
ma'am.
no
Actually,
clear
clear cut
guideline.
evidence. Yes, ma'am.
But even if you go for maintenance, you need to stop it if the baby is
Yes.
seizure free for 72 hours.
Yes, ma'am.
Yeah.
Yes, ma'am.
It is mainly dependent on what etiology you are facing with. So it's if you are very acute symptomatic seizures, then you may not need the maintenance. Had it been not, then you may require maintenance and end up adding up to another anti-seizure medication also.
Yes. Thank you.
So thank you so much.
you.
It was an extensive and very nice presentation by Anish.
Thank
So
you.
you spoke for almost 2 hours continuously, and both the experts were giving their opinions and discussing it. It was really a wonderful discussion. Thank you so much. Thank you, Madam and her sir both. The PG students, even though those who are not DM, they have already are also be enlightened with this. Nihal, Rajat, they are all the MD students, but they also enjoyed the discussion. So I thank you Clarinet also for providing this platform, and thank you Somsekhar sir for being here constantly for 2 hours. Otherwise, sir is having so many meetings that to have sir for 2 hours is a actually joy. Thank you so much, sir.
Thank you.
Thank you so much for the opportunity. Excellent presentation, Anish.
Thank you, ma'am.
Really, it's
Thank you,
vast
ma'am.
and extensive presentation.
Thank you.